So let me just once again welcome JoAnn Manson to the Oral History Alma de Morani Renaissance Women in Medicine project run by the Women in Medicine Legacy Foundation.
It's great to
Dr.
see you
Manson
again.
Yeah, thank you very much. And I know we left off, you were just telling us about entering into medical school and why you chose Case Western with the integrated organ system training and also clinical experience in the early first year of medical school that appealed to you. But I don't think we really got a chance. I wanted to ask you what it was like to leave the undergraduate college world and enter this professional training program. Did they have white coat ceremonies back then? Was it a big threshold? Were you excited? How did you feel about this new commitment really to a professional path, which undergraduate college leaves us free to go in multiple directions, but this is really a commitment. So how did you feel about all that?
I was very excited to be going to medical school, and I was glad to be going back home after 4 years in Cambridge and Boston. So it's good to go back home. And I was excited about the Case Western Reserve curriculum, as I'd mentioned, having early exposure to patients. And often the way they do it is to have you working with the patient during her pregnancy and following her through the obstetrics clinic visits, and then through labor and delivery, and then when the baby's born to follow the baby through pediatric clinic. And I thought it was really a great opportunity to have that early clinical exposure and have that context for learning medicine, to really see how it's applied to the patient. And so I was looking forward to that. And also, as I mentioned, the integrated curriculum just seemed like a really sensible approach to maintain interest, keeping it as clinically relevant as possible, throughout the training year, throughout the early years of medical school into the more clinically based years when you're actually fully in the clinic and spending all of your time with patient care. So I thought that those were really great strengths of the program that I was looking forward to. And I enjoyed medical school a lot.
Yes.
That I thought the teaching was terrific. The professors and lecturers seemed so committed to teaching and sharing their knowledge. I was very impressed by the amount of time that was spent by so many of the teachers, and the other students, for the most part, were fantastic. Had a lot of close friends and colleagues that I developed during those years. So overall, I would say is very positive. Of course, it's hard work and the hours were long. And especially, once the clinical years began in terms of being like full-time at the hospitals, it was demanding. But I always enjoyed it, and I always felt like it was a privilege to be able to talk with patients, to learn about them, that they would trust a medical student. In those days, I mean, they were aware that many of us were they were seeing in the hospital or in the clinic setting were students in training. Right. And so often they would be really, really generous and kind about wanting to help with the training, to talk with you, to entrust their care to you, even though they knew, of course, it wasn't just the medical student, working with them. But I did always feel it was a privilege to have that opportunity. And so all of that was very positive. And for a long time, I was thinking that I would do full-time clinical practice. I really was thinking mostly in terms of going into clinical medicine, not so much into research specifically or administration. And so that was my focus, learning clinical medicine and being as good a clinician
Yes.
as I could become. And so overall, I think the training was really good. And I was particularly inspired by some of the teaching in the field of diabetes and endocrinology. I became really interested in that field because I could see that especially with type 2 diabetes, or what was then often called adult onset
Yes.
diabetes, there were many opportunities for prevention. And that seemed really to be a great focus, to be working with patients, to try to reduce their risk, talk about what information is available about things that they can do, lifestyle behaviors, other factors, that controlling those factors and taking charge of their health could make a big difference. That part was very exciting to me. So from the very beginning,
that unusual, do you think? Because I spent 10 years in medical education, and often the focus of the education is curative. How can we cure? And I recognize that I think today there's more emphasis on preventive medicine, certainly from researchers like you have helped push the needle. But in your own, were you one of few who got excited about preventative medicine? Because sometimes I think medical training tends to emphasize what we can do to cure and treat as opposed to what we can do to prevent. So were you unusual? Was there a mentor or someone who lit you up about this idea of prevention, or was it just something that grabbed you? How do you think you came? And were you an anomaly? Because I think in some settings, in some medical schools, you might have been. So I don't know if you were where you were, but just curious to know.
Yeah, I think that it may have been more atypical to be interested in prevention. I was also really interested in treatment and what modalities of treatment were available, but I really began to understand that it's the healthcare system in the United States is really a disease care system.
Yes.
And there is very little focus on prevention and health promotion or maintaining health. So in some ways, it's a misnomer to be calling it healthcare. It is very much disease care oriented. And I would like to see that changed to be more health care, prevention of chronic disease, prevention of disease focus. But I think I had several teachers who did put a focus on preventability of some of these conditions. And so that really helped to inspire me. I think this was one of the reasons why after doing my training in internal medicine, I pursued endocrinology as a subspecialty, because that is diabetes, includes diabetes as a major focus, as well as other conditions that are considered endocrine disorders. And I think with diabetes in particular, there are so many opportunities for prevention.
I'm curious too, early when you mentioned, this is a place where clinical care started in the first year and often following pregnant women and then their early child years. Did all the men also have the same obstetrics, gynecology, pregnancy? That's an interesting focus for both genders to be interested in women's reproductive health and childbearing.
So with all of the students, it was this early clinical care that usually would involve pregnancy, a woman during her pregnancy, labor delivery and then
Uh-huh.
pediatric clinic. So in some cases, a pregnancy was already fairly far along, so it may not
Right.
be a full 9 months of
Right.
obstetric clinics. And much of the focus was on the pediatric following
Okay.
the baby
Okay.
and the infant during that first year of life. Um, so it was very similar
Okay.
for the men and the women.
Interesting. And because there was an imbalance of men and women, what did the faculty look like? If the students looked 4-1, what did your faculty look like? Was it easy to be a minority in that group of students? Did you feel included, accepted, equal, or were there challenges to being a woman? I would think that women physicians were becoming more common, but certainly not to the point we would acknowledge today.
The years I was there, it was again a 4-1 ratio. So this was very familiar to
Yes.
me. And it didn't seem at all unusual in that
Right.
I had just gone through 4 years of college where there was this 4-1 ratio, and now it was again 4-1. But I never really felt that there was any discrimination
Okay.
against the female students. Um,
Hmm.
and I know that some medical students have talked about experiencing that. I think it can be very individual in
Right.
terms of what the
Right.
experiences are. Um, there may have been a few cases where I thought there was some unequal treatment, maybe on the wards in the hospitals
Ah.
with
Mhm.
certain attending physicians or
Okay.
um, the residents, the physicians in training. Um, but for the most part, I thought it was extremely equitable, and that there was an interest on the part of the attending physicians and the residents and junior residents who work and interns, because we're talking about the medical student years. So they're all these house officers, interns and residents and attendings were also working with the medical students. And I thought that overall, there wasn't discrimination against the female students. There was a real respect for the fact that these are going to be female physicians soon,
Mhm.
when they
Mhm.
finish medical school, and that there's also a tremendous need for women physicians, because many patients do prefer, many women, especially in certain areas of obstetrics, gynecology, some women, when they're seeking the pediatrician for the child, will seek out a woman physician. So I think
Yes.
there was a recognition that this is really serving a role for patients, as well as just having a fair society.
Mhm.
That's more equitable. So I didn't believe that there was much discrimination against the women students. I was not seeing much evidence for that.
Yeah. No, that's good to hear. I do hear different stories, but I think you point out wisely the institution you're in, the personalities that are there. These things can all make a difference in how you experience being a minority in a given situation. And the social recognition, as you said, that we do need for patient care reasons to graduate some female physicians. I think that's important too. And I hadn't thought about what the conversations might have been at the time about the need for this. So yeah,
I
that's
mean,
really
one area
interesting.
I will mention is that occasionally with some of the male interns, residents, there would be like you would feel that they were maybe interested in you romantically, and that could be
Ah,
uncomfortable,
okay.
that kind of thing. But it usually could be managed, and because Chris and I were already together,
Yeah.
and we were already involved from college on. I didn't feel that was a specific problem for me in terms of handling being asked out or
Right, right.
that type of thing. But I could see how for some of the female students that could
Yes.
become a problem. So I think it's very individual based on their own personal experiences and their own a lot of different personal factors, individual factors.
And I think even today, many workplaces struggle for professional environments for
Yes,
women and men. So I can see that
it's
that would
not, it is by no means unique
to
to
medicine.
the healthcare system or to the hospital environment.
Right, exactly. No, that's really interesting. I did read somewhere in an interview I read that you gave that you mentioned that the curriculum in medical school at that time was still very much the male model, the emphasis on male understandings of cardiovascular disease or others. I'm sure you can elaborate more than I can, but I did
Yes,
catch
that
that and I
that
wanted
is
to ask you.
something that we can talk about. I think of that as somewhat separate from actually feeling that the female
Yes,
students were being slighted in some way
yes.
or treated differently or discriminated against. But without question, the curriculum, even at a school that had a very innovative curriculum and really tried very hard to be on the vanguard of
Mm-hmm,
change in
mm-hmm.
medical education. I think it was just so steeped in the tradition of medicine to teach this male model of physiology and anatomy and disease, so that often the paradigm would be they would call it the 70-kilogram male,
Right.
would require this much medication or this type of, would have typically this blood pressure or this, these various metrics and numbers.
Yes.
And there was very much a focus on that paradigm without question. And very rarely would you see, specifically a woman, except in the OBGYN or
Right.
where we're talking about female specific conditions. Even in talking about conditions that were much more prevalent in women,
Uh-huh.
very
Uh-huh.
often the paradigm was the male patient, and the diagrams and images were of male patients. And it would be
Wow.
rare to have the lecturers and the professors actually talking about sex differences,
Right.
differences in symptoms, presentation, treatment, um, reactions to medications, different dosing of medications. Much of this information was actually not available at that
Uh-huh.
time.
Uh-huh.
But because it was also affecting the research that there was this the male paradigm, and there was not this strong interest in understanding sex-specific conditions, sex differences in diagnosis and treatment, and and so a lot of that research was limited, given short shrift, and the information was not even available to teach in medical schools. I think there's a slow but progressive change in that. There's more integration of sex differences and conditions specific to women. For example, there may be incorporated into autoimmune diseases,
Right.
all of the differences in terms of the immune system of men and women, and many conditions like lupus and rheumatoid arthritis that are so much more common in women. Even in terms of heart disease, we know so much more now about differences in presentation, symptoms, diagnostic tests, different types of heart disease that may be more common, like a type of heart failure with preserved ejection fraction, and atrial fibrillation in women being more likely to lead to stroke. So there's a greater appreciation of the sex differences and even some dosing of medication differences. But it's still, even, I mean, we're talking in August of 2024, it is still limited. There is a need for so much more research on these questions of, sex differences, what we often call sex and gender informed care of the patient. It's really very limited.
So the research I know has grown, the integration of it into care, training, education perhaps has lagged, or is there needs on both sides? Both
There are
research.
needs, there are absolutely needs on both sides, with the research as well as the teaching and the curriculum development. But even when there is some research that would suggest there should be some focus on sex-specific differences, sex and gender-informed medicine, it is not necessarily incorporated into the curriculum. Here's an example, and we'll probably come back to this later. With the menopause, there is very little training of medical students or clinicians on menopause and menopause transition, perimenopause, the available treatments for symptoms like hot flashes, night sweats, and all that. And the amount of training really decreased after the Women's Health Initiative results suggested that hormone therapy may not have a favorable benefit risk ratio for prevention of chronic disease. And that led to a major decline in hormone therapy use and less teaching about menopause. But menopause now is currently 1/3 to even 40% of the average woman's life. And it is a field that is a topic that is so neglected in medical school and in the clinical training years, as well as, well past internship residency years. There are many clinicians do not have adequate training in that area.
So as though if it doesn't turn out to be something to do with chronic, if we can't treat it as a piece of treating chronic disease, it's not important enough on its own, even though it's 40% of women's life spent in menopausal years, it doesn't get the same kind of attention just because.
That's part of it. If it can't be put into that particular category of this is exactly how you treat it, everyone agrees that this is the approach. I mean, even just having the discussion with the patient and asking certain questions becomes very challenging for the clinician, when they don't have this training, and patients
will ask questions and not know what to suggest if they haven't been
they're not even comfortable often in framing the questions and asking questions, and patients are often uncomfortable bringing up these topics. And this is really an area where shared decision making between the patient and the clinician is so important. It really needs to be a conversation, discussion of options, and then the patient really sharing and making decisions about what route to take.
Best course, yes. This kind of lack of attention to sex differences and gender-informed care, is this something you noticed as a medical student, or was this looking back? You did, even then.
I noticed it. We would talk, among many of the women students in class, that they were always hearing about this 70-kilogram male. In some ways we would be amazed by it, that was so often the image that was presented, and so often the reference point for what we were learning. But it just, after a while, seemed just to be the way it was. And we were so busy trying to learn everything and doing the training, that you couldn't really, at that point, focus as much on activism and trying
Being a
to
critical voice as a medical student is probably not
right. So
widely available to most.
I think the changes really needed to come from people after they completed medical school, though some changes I think can be instigated by the students themselves.
Yes.
And I think that students are increasingly vocal and active in asking for certain types of training, teaching and training, education in the curriculum, topics in the curriculum. So there are some very positive changes
sort of
in that
round
direction.
up sorts of movements. I think as we put more diversity in medical schools, we'll see what we've thought of as the norm get disrupted. So when you put women in, you
Right.
see things. When you put ethnic minorities in, you see things.
Exactly.
Yeah.
I think, you know, as we were discussing, when the medical school classes were only 1/4 women, it may have been more difficult. Now the medical school classes are really at parity for quite a
Yes.
while, and 50% women, there and many more of the professors and teachers are women. I think there's going to be more change over time, even more change over time.
Yeah, I think so. One of the things I wanted to ask you is there a point in those 4 years as you're moving into clinical experiences across them and as you're absorbing things, is there a point you started to feel like a doctor, or did that come later as you moved into your residencies? When is there a point at which you felt like, yes, I am a doctor. I know myself to be a physician.
I think it's a gradual process in terms of your identity as a physician. Um, I felt that once I was in the clinic and actually being given responsibility for some decision making and working closely with patients and making diagnoses, that I began to feel more of that identity. However, I personally felt it really came after receiving the MD degree
Okay.
and during you know the internship residency years, but it's a very gradual process.
Right.
And again, this is why in many ways it is so surprising that patients can entrust their care to students and
Who don't
trainees.
even feel themselves to be a physician.
Yeah.
Yes.
And you know, very often there would be like specific patients who would want so badly to call you doctor, even though you would keep reminding them that you're a medical student and your doctor is named so and so. They would just totally, there were many cases where they would just totally accept you as the doctor and even ask for you as the doctor to be the
Okay.
one to talk
Right.
with.
Right. Yeah. I'm also thinking I'd like to hear a little more about your residency, but I believe from what I've looked at in dates, as you come to the end of your MD, it's also the time when you lose your mother, you get married. And I thought, well, maybe we'll take a moment and think about those personal transitions that were happening. I know you told us last time that the loss of your mother to ovarian cancer was a real motivator for thinking what we don't know about women's health, why we need to know more. And you mentioned that last time, but this comes right at a moment of celebration for most people. I mean, I don't know exactly how things played out, but you know, receiving your MD is a big moment for many students. So
Right,
I wondered if you'd touch
right.
on that.
So it was a tumultuous time, a lot happening. I'd already made a commitment to be in an internship and residency program in Boston. So I was already leaving home again. And Chris and I got married, you know, right at that time, very shortly after I graduated from medical school, and he graduated from law school because he
Okay.
was together with me in Cleveland at Case Western Law School. where he was at.
Okay, so you both moved to Cleveland and did the next stage of
Yes,
professional
we were
training.
both in Cleveland together, and then moved back to Boston. And so it was a very, very difficult internship year
Oh, I
for
bet.
me. And my mother she had very advanced cancer when it was diagnosed.
Oh,
There were maybe a few months of her condition improving when she was actually able to do things, but it was already very advanced at the time it was diagnosed. And in fact, as so often happens with ovarian cancer, um, the the cancer is diagnosed at a very late stage, at a very advanced stage, and the symptoms can be fairly non-specific, what's called non-specific, but I think it also reflects that in the medical field, especially at that time, there wasn't as much of a focus on conditions that were female specific diseases or female specific cancers. Over the years, breast cancer has gotten, much more attention, very
right.
fortunately, and ovarian cancer has gotten more attention, but it's still really understudied, and there still is not a terrific treatment. So the cancer was very advanced, and I am doing my internship and night call and working really hard. And any chance I ever had to go take a break and go, and take time off, I would go home to see her. It was just a very tough time. I took like no true vacation time during that
Right.
period when I was doing a lot of night call and doing, the internship. So I would just say it was a very difficult time that really underscored for me how how little is known about women's health and conditions specific to women, specifically for ovarian cancer. So little was known, that it's a cancer so often diagnosed at very late stages. And this really motivated me as I was thinking about what field do I want to pursue to be more involved with women's health related
Okay.
conditions, whether it's at that time, I wasn't thinking that I would
Necessarily
necessarily focus on cancer because it actually seemed painful
Right.
to,
I can imagine.
to have
Yes.
that focus.
Mm-hmm.
But I became really interested in the field of women's health. And I knew that whether it was clinical practice or some combination of clinical practice and research, that a large percentage of my patients would be women, and that I would be focusing a lot on sex differences and conditions that were specific to women or more common in women.
Right.
And so I did pursue that. And my junior residency year, after internship and my mother had died, I began applying to endocrine fellowships, and
Right.
I decided, that I would do the endocrine fellowship route. And then as I was doing my endocrine fellowship, I saw so much chronic disease that seemed highly preventable. And that really, for me,
Mm.
just underscored that prevention and research on prevention was what I wanted to focus on most. Because I was seeing a lot of patients with type 2 diabetes and type 1 diabetes
Is
who
diabetes
already,
considered an endocrine disease? This is
Yes,
Yes,
that is
okay.
considered part of
Yeah.
endocrinology.
Yes, okay.
So in my during my training and during the clinics I was doing during my endocrine fellowship, I was seeing a lot of patients with very advanced complications of diabetes, because in those days, you know, we're talking about before a lot of these newer treatments were available to reduce risks of complications. There were many patients who had, let's say, longer duration of diabetes and had not only the what's called small vessel disease, like the vision loss, kidney disease, nerve damage, but also had heart disease, stroke, greater risk of many of the cardiovascular complications. And cardiovascular disease was, you know, is still the leading cause of death among people with diabetes. And I became really interested in the topic of what can be done to reduce the risk of type 2 diabetes, which was increasingly common, increasingly prevalent, and was almost, even in those years, becoming epidemic. I mean, now it is even higher level, very, very high levels that are tracking with some of the other trends, you know, in terms of changes in the prevalence of obesity and, you know, other risk factors. But I really did want to do research on understanding better how to prevent type 2 diabetes and cardiovascular disease and cancer. So these were, you know, the areas I really wanted to focus on. And, you know, we've done certain estimates in our research of the percentage of these conditions that are preventable, modifiable. And the numbers are, these estimates are actually just staggering, because for type 2 diabetes, we and others have estimated that close to 90% of
I had no idea.
Yes, type 2 diabetes could be preventable with various lifestyle, behavioral change. Of course, it's not just as simple as telling people to change their lifestyle, because many people don't have access to, you know, healthy foods and affordable, you know, healthy diet, and safe places to walk and be physically active. And so it's, in many ways, it's a complex societal issue as well. But if you look at risk factors such as let's say a diet, or let's look at it the positive side, the healthy part. If you have a healthy diet, you have regular physical activity, you don't smoke, you maintain a healthy weight, and you also have, you do not have excessive alcohol intake, even just those factors alone are related to about having a 90% lower risk of developing type 2 diabetes. Now, with heart disease, with heart attacks and coronary heart disease, these estimates are 80% reduction that is achievable through factors such as healthy diet, healthy regular physical activity, maintaining healthy weight, avoiding excessive alcohol intake. Also controlling blood pressure, which, you know, is a preventable, treatable condition, and treating high cholesterol. You know, these are all conditions that are, it's so preventable. 80%. With stroke, the estimates are close to 70%. And with cancer, it's close to 40-50%. It's, you know, very substantial. A paper was just published suggesting that dementia, you know, which is often considered an inevitable consequence of aging, and also having a strong genetic component,
Yes.
is
So
also
therefore inescapable.
highly preventable. That the most recent estimates this was from the UK, but the most recent estimates were 50% preventable. 50% of cases worldwide of dementia may be preventable by various, modifiable risk factors.
Right.
And I think that there's so much
Mm.
potential
Mm-hmm.
for prevention. It's really in terms of population health. Um, Prevention is very powerful. And I became interested in this area, also interested in doing randomized clinical trials,
Yes.
because I think that the observational research is really important in generating hypotheses to be tested in randomized trials. And when the associations are just extremely strong, such as with smoking
Uh-huh.
and risk of lung cancer or even cardiovascular disease, you don't need randomized trials. You can just move forward with public health campaigns, various ways of
Right.
intervening and reducing smoking. But with
Oh.
experimental evidence goes so far in
Mm-hmm.
actually leading to clinician change and leading to public health measures.
When you announce those kind of figures, that so much of what we consider to be inescapable or, genetically based or deterministic, to be actually preventable at those kind of rates. When did you start? I'm astonished. When did you sort of stumble around and think, this is astonishing? You've already said the curative model, the disease model of medicine needs to be adjusted to a healthcare model. But was there a point in your evolution as a physician where this became, this is astonishing, this is a commitment I want to make? Would you say that was during your residency?
I
Has it
think
been
some of it
growing across your
started,
career?
I think some of it started in medical school, just
Yeah.
seeing how much of the chronic disease did seem to be related, not only to behavioral factors, but also to like social determinants of health, where you
Yes.
live, the zip code
Yes.
being more important than the genetic code.
Was that being
That
introduced in
was
medical school
starting
back then?
even then there was, an awareness of that,
Okay.
not to the point where you'd be writing papers saying
Right.
it
Okay.
very forcefully. But where I really became impressed by this, I would say, as I worked more and more in the field of type 2 diabetes. And I just,
Okay.
and so some of that was during the internship, during, internship and residency, but a lot of it was also my endocrine fellowship. And that's when I decided that I did want to train in public health
Yeah.
and go back to school in terms of learning research, methodology, study design, biostatistics, and doing that type of training so that I could do research in these areas.
Okay. That helps me just to place, like, is this like a late arrival or an early arrival? This kind of, astonishing almost sense. The other thing I thought I'd ask you about, I'm watching our time a little bit to be mindful of your stop time. So rather than get into your MPH and the world of research, we'll leave that for next time. But I did want to ask you, during your internship and residency, and I just want to say, an internship in the shadow of your mother's disease and death, I can't even imagine, because everyone I speak to tells me how intensive those internships are. And
Yes.
I don't know how you manage that. It must have been a struggle. But so you told me during your medical school years, there was encouragement, women were seen at parity and almost needed. There was no out and out discrimination. Did that environment continue when you moved back to Boston? You're at Harvard Medical Schools doing your internships and residency. Did you still feel as a woman in endocrine research and clinical skills? Am I equal? Am I on par? Did you face the same kind of, this is not problematic, or was there different challenges in those years as a woman?
I think in general, I didn't feel that there was direct discrimination by my supervisors and professors, attendings. There were certainly some individual examples, in individual cases where I thought that the females on the wards were in the hospital were not being given as much credibility and as much attention in the training, as many opportunities to do procedures and to get specific training. I felt that with a few of the supervisors and attendings and mentors. But for the most part, I didn't feel that the women, or I specifically, was facing
Right.
discrimination.
Not systemic. Yes, okay.
Yeah, I did not feel it was systemic. I thought it was more on an individual basis. There were some of the attendings who paid more attention to the male interns, residents, and trainees, and gave them more opportunities.
Did you feel that was something you needed to address in some way to make sure you got the training you needed? Or did you think it was something to just step around and keep going? How did you fathom what to do in those cases when that did happen?
I think that I learned to become more assertive. You know, I would specifically ask for certain opportunities. I remember for a while, I even considered pursuing surgery,
Right.
and did a summer program, you know, at a hospital where I worked with a vascular surgeon and spent like eight weeks just getting a lot of experience being in the operating room and assisting with procedures. But I felt that I really needed to seek out those opportunities specifically, or I might not get
Miss them
them.
altogether. But you didn't stick with the idea of being a surgeon.
No, I definitely decided against it. And I mean, it's a great field. There are lots of great surgical, you know, fields to go into, but I was really much more interested in internal medicine and endocrinology. I was interested in really these continuous longer term relationships with patients and working with them long term, and including on ways that they can be empowered to take charge of their health. And that seemed more achievable in internal medicine, endocrinology, than in a surgical field, though I think that there are other advantages of other specialties, but that was my choice.
Yeah, I don't see surgery taking up a sort of mantle of prevention and population health in quite the same ways.
Yeah,
that
I think there are some differences in that regard.
Yeah. No, that's really interesting, and I thank you for that. And I think that'll leave us at a nice sort of junction to take up next week, you know, adding the science and research piece in such a deliberate and dedicated way as to going off and learning the tools of research. And I will be curious to hear, you know, as a woman now in science, what is the climate there? What is the environment there? And how did that go for you? So I won't get there today because I know we have to be a little mindful of time, and those are rich questions.